The next mycobacterial species we'll talk about is Mycobacterium leprae. Mycobacterium leprae is the causative agent of leprosy. This is not a common infection in the United States. The normal reservoir host in the US, though, is the armadillo, weirdly enough. There are two different forms of leprosy, and it really depends on the host's immune status, which manifestation of disease they would have. The table on the left shows the two different types of leprosy: tuberculoid leprosy and leprodermatous leprosy. Tuberculoid leprosy could, almost be considered the more minor form of leprosy. There are few lesions. There is going to be some nerve damage. There's going to be enlargement of nerves. You'll see infiltration of lymphocytes in the area. It is relatively low infectivity, and it's characterized by a delayed hypersensitivity response, and there are going to be normal levels of antibodies. The leprodermatous form is the more dangerous form. This is usually the result of having a more robust infection, so often because the patient, for whatever reason, either has some sort of immune deficiency or just a more genetic predisposition to developing the type of infection. Because humans all have different immune systems, some people can be exposed to the exact same amount of pathogen at the exact same time and have wildly different responses. In the leprodermatous form, you're going to have way more of these lesions, which usually don't have any pain. There's going to be no nerve sensation, and they'll have extensive tissue destruction. Now, this tissue destruction is not necessarily caused by the M. leprae itself. It can often be caused by secondary infections because of the lack of sensation, not realizing you have an infection, or the immune suppression caused by trying to fight the M. leprae. Other organisms can take hold. And it can also induce basically the resorption of cartilage, so that would affect the nose and the ears. Under histopathology, you'll see what are called foamy macrophages. So any type of foamy cell is just a cell that has big pockets of cholesterol, so it looks kind of like soap bubbles under a microscope. And you'll find lots and lots and lots of bacteria. So see here you have lots of acid-fast rods. Here you have few to no acid-fast rods. So the tuberculoid form is mostly characterized by having a lower burden of infection. The leprodermatous form has a higher infectivity, mostly because the patient has more bacteria to transmit. The patient may also have hypergammaglobulinemia, which is just a big long word for saying lots of extra IgG. So gamma globulin is IgG. Hyper means a lot more. So I told you that armadillos in the US are the reservoirs for leprosy, but based on molecular genetic analysis, it appears that the armadillos in the US, like Texas, Louisiana, actually did not carry leprosy until colonists from Europe brought leprosy to the US. So colonists from Europe, they did a lot of damage to the US, including infecting armadillos with leprosy. So the armadillos just give it back every now and then. So this is a picture I took when I lived in Texas. I was going to go hiking at a park about an hour outside of San Antonio, and I saw this dead armadillo on the side of the road. And when we were coming back from the park, somebody had put a can of beer in its hands. And so this is, I know it's going to sound really weird, but it's kind of a thing in Texas, I guess. I didn't touch it. I didn't do it. This was some person in Texas who did that. But I took a picture because I thought it was weird. So again, here's that same table showing the two forms of disease. You can really see the extensive tissue destruction. For a long time, people didn't know how leprosy was transmitted, so they would isolate people with leprosy into what were called leper colonies. There were some in the United States, and so people who had leprosy were basically living out their lives in these colonies. Here they're showing the incidence of leprosy. You see in India, Brazil, they have higher incidence. Some parts of sub-Saharan Africa. We do have a little bit in the US, but not a ton. And then in these other countries that are in gray, there was no leprosy reported. There are other slow-growing Mycobacterium that cause disease, but for the most part, we don't see these diseases in our patients unless our patients are immune compromised. So the bacteria are grouped into what's called the Mycobacterium avium complex, or MAC complex. The MAC is the complex. And these Mycobacterium avium, as you might suspect from the name, causes avian tuberculosis. However, there are some subspecies that can cause disease in immune-compromised patients. You see HIV patients, children with cancer or cystic fibrosis, and then Mycobacterium intracellular, which can cause pulmonary disease, again, in your immune-compromised patients. So these aren't super common, but they can happen. So it's something to be on the lookout for. There are fast-growing mycobacterial species. They rarely cause disease. They're not super common. However, they can cause infection if they get in through trauma or as a hospital-acquired infection, basically caused by medical treatment. So any sort of like surgical wound, injection site. Because most drugs that treat mycobacterial infections are actually designed to treat specifically tuberculosis, and they are supposed to work against these slow-growing organisms, a lot of the faster-growing mycobacteria are actually resistant to these classic anti-mycobacterial drugs, but are susceptible to other types of drugs because they are more rapidly growing. So right now all the nail salons are closed, so this is not a worry, but the nail salons will open up, and I will be there, but I will not, hopefully, get a mycobacterial infection. So there were 4 female patients reported to the California Department of Public Health who had lower extremity, basically boils on their lower limbs. So they were originally small and red, they became large, tender, they had fluid in them, and then they were kind of a reddish purple color. The cultures were negative. The patients failed normal therapy. They had all been to the same nail salon before the lesions developed. As a result of the investigation, a total of 110 patients with boils were identified. A Mycobacterium species was able to be cultured from the lesions of 32 patients, as well as from the foot baths used before the pedicure. Shaving the legs was identified as a risk factor for disease. You are taking a sharp razor, scraping it along your skin to hopefully remove your leg hair. You're probably going to introduce sometimes big cuts, oftentimes very little cuts. So it is highly recommended that you do not shave your legs immediately before going to get a pedicure. Go in there with the stubble, it's all good. Similar outbreaks have been reported in the literature, which illustrates the risk associated with water contamination with the rapidly growing Mycobacterium, the difficulties in confirming these infections by routine bacterial culture, and the need for effective antibiotic therapy. One of the classic antibiotics that's used to treat some of the slow-growing mycobacterial infections is called isoniazid. There are a couple of others that are used for treating tuberculosis. And so isoniazid and some of these other anti-mycobacterial antibiotics, especially the ones that work against the slow-growing form, actually work by inhibiting the synthesis of mycolic acids. So they would only work against mycobacterial species and not any others, but they are pretty effective at inhibiting that mycolic acid biosynthesis. The last group of acid-fast bacteria that we'll talk about that can cause human disease, but they aren't super common, are members of the genus Nocardia. So these again are strict aerobic rods. They are acid-fast and they form these branched filaments. That's kind of what it would look like under a microscope. They have shorter length mycolic acids, so they stain what they call weakly acid-fast. This is helpful because it can allow clinicians to distinguish Nocardia from actinomyces, which is another aerobic branched filament growing bacterium. The colonies can appear variable on a plate, so you have some large, some small. You don't have that kind of uniformity in colony formation, and they can even form aerial hyphae with these branched filaments. So along with actinomyces and some of the other bacteria we'll talk about later, people used to think that these were fungi because this is what a fungus would look like on a plate as well. But they are not fungi, they are bacteria. They can avoid killing by the phagocyte. They have enzymes like superoxide dismutase to deal with superoxide radicals. They have catalase to deal with the hydrogen peroxide produced by the immune system. They replicate inside of macrophages, so they are very happy to be phagocytized. They can prevent fusion of the phagolysosome. So remember, they'll be engulfed. The phagosome will fuse with the lysosome, and then there are enzymes and a change in the pH in the lysosome that when it binds to the phagosome should kill the bacterium. But Nocardia is able to prevent acidification of the phagosome, which prevents killing. These are what we call exogenous infections. We do not carry Nocardia on our bodies. That would be an endogenous source of infection. So you have to get the infection from somewhere else. And they are more common in the immune compromised. So generally, if you have a patient who is otherwise relatively healthy, you will not see a Nocardia infection. This is somebody who is compromised in some way. And the general manifestations of disease are going to be either cutaneous or respiratory. So here in this patient, you see on the left-hand side, the middle finger is red and swollen. The whole hand is red up to the wrist. And you see these like weird, gross lesions on the back of the hand. That's a Nocardia cutaneous infection. But you can tell by looking at the otherwise healthy hand, this is probably an elderly patient. The skin is very thin, the veins are popped out, there's lots of wrinkles. Elderly patients are just in general more immune compromised than people who are younger. So this type of infection would be something you might see in an elderly patient. Here are some of the clinical summaries of disease: bronchopulmonary disease, destruction of tissue, lymphocutaneous, cellulitis, and subcutaneous abscesses, brain abscesses. So Nocardia can cause really, really significant infection, but again, this is not going to be something you would suspect unless your patient was already immune compromised or elderly, some sort of underlying complication. In a young, healthy individual, this is not what we would see. So here's a patient who has disseminated Nocardia infection, a 63-year-old man who received a liver transplant for liver cirrhosis caused by hepatitis C. So this patient has hepatitis C. That's a really significant viral infection in the liver. He has liver cirrhosis. So the liver is really important for helping to detoxify your bloodstream and the rest of your body, basically. So you have a virus, you have a liver that doesn't work, so you get a liver transplant. In order to do transplantation, you see here, the patient was treated with immunosuppressive drugs. You have to suppress that person's immune system, or their immune system will destroy the transplanted organ. So any of your patients who have ever received a transplant are going to be on immunosuppressive drugs and are going to be considered immune compromised. So 4 months after the transplant, he returned to the hospital, fever, lower leg pain. X-ray was normal. Ultrasound revealed an abscess in the soleus muscle. The soleus muscle is in the back of the leg. It's part of the calf, so that's why we had lower leg pain. They identified poorly staining gram-positive rods. So again, remember on Nocardia, our mycolic acids are much shorter. So this would more likely allow the gram stain, the crystal violet, to get in. But you see poorly staining, so it didn't stain nearly as well as another cell might. Nocardia grew 3 days after incubation. Treatment with imipenem was started. Imipenem is a drug belonging to the class of carbapenems. They are cell wall inhibitors. However, the patient developed convulsions and partial left-sided paralysis. Brain imaging revealed 3 lesions. Treatment was switched to ceftriaxone and amikacin. These are just stronger antibiotics. The subcutaneous abscess and brain lesions improved, and the patient was discharged 55 days after hospitalization. This illustrates the propensity of nocardia to infect your immune-compromised patients and disseminate to the brain, the slow rate of growth of the organism in culture, and the need for prolonged treatment. So again, not a common disease, not a common manifestation. You're not going to have tons and tons of patients that are on immunosuppressive drugs unless you are a transplant surgeon. So this is just something to be aware of, but not going to be your first thought for a patient's infection.